So today, I'm really excited to maybe which I'm sure of, it's the Middle East. First to do the hands-on. So simply today that and broke up the team. So we have a team to be able to do this today. First of all, I would like to thank Professor Mohammed Al-Adi, my friend from now more than 25 years, to join us for the first session. We have in the room here 2 nurses, so Salma and Rania. Salma is our head nurse and Rania is on from our team, from Roya team. So I will let Adi do everything today. I will do nothing. But on the other side, I would like to thank few people behind the scene. So we have here for this broadcasting, we have the team from Mawahib. So thank you all of them. So really, they are doing great work to do all of this. From our team, from Roya team, everything is managed by Dr. Nuran Roshdi. So she's my daughter, and she's doing a lot of work for all of this. Also, I would like to ask to thank Marwan Ashraf, our new, I would say, runner in the team. So he's doing a lot of job in the back office. And lastly, our new cooperation with Tanzim company. So they are helping us in this broadcasting to be in the professional way. So I would like to thank everyone. I will let Adi to start. So please, Adi.
Okay, hello everybody. First of all, I'd like to thank Professor Ibrahim Mustafa for being with us. This is a very great honor for us, and thanks to my great friend Mustafa. He's a like brother for me, and I'd like also to thank the 2 great nurses who are going to work with me. This is Salma and this is Rania. And thanks to Ru'ya Training Center and AstraZeneca for doing this first virtual hands-on training. So, first of all, I'd like to talk about what I'm using now. This is Ru'ya module for
focus على الموديل الأول.
This is Ru'ya module for polypectomy, and when I'm getting inside, I will tell you what's inside it. And the second thing, this is the Fuji system endoscopy, and this is the 5 series upper endoscopy with 2.8 channel. And also, I'm using some accessories, all of them from Boston Scientific. So we will start with introducing the accessories we are using now.
Dr.
So
Adi,
the first
Dr.
accessory
Adi.
we are using.
Dr. Adi.
Yes.
When you speak
yes.
endoscope by 2.8 channel, sometimes you can use a channel endoscope with higher channel, where it's enough for all the accessories.
Well, according to the technique, the 2.8 channel is the least channel in the upper endoscopy devices, but it's enough for most of the techniques except some minimal techniques like duodenal stenting or what's called stenting through the scoop. But if you are doing techniques like polypectomy, like we are going today, or doing EMR, it will be enough.
Okay, just one comment before Adi starts. We have also for all the attendees, so please feel free to send questions. We have a new system here that this question will appear in front of us here, and then we can answer your question throughout the session. So please.
Okay, the first accessory I'm going to use here. This is the injector, the needle injector, and it's 200 centimeter length, so it's working in the upper endoscope. And it's a 20 mucosal injection.
I will help you.
You can open it if the
yes. So I think this is also very important because in Egypt, especially in the varices, we are accustomed to the 21 gauge needle, but for the polypectomy, you need a smaller needle. So you don't need a 21 gauge needle like the varices. 23 is enough for injection. One of the things also for this needle, the lock system. So you can see here this thing that, there is nothing to adjust. If you just push, so it will be locked. So if you can, please, if you can focus on the second hand here.
Yes, we can
yes,
do it.
You can do it.
Do it.
Yes.
Yes.
So yes, focus a little bit, zoom a little bit. Yes. So perfect. So it's only if I go back, and then it's only the needle out. So there is no any fear of doing more or less. And you have this part of the needle, that this is also another very important, especially when you are injecting really, especially maybe in varices. Sometimes you need, the needle breaks. So one of the good things in this injector needle that you have here, if I can focus this, so it can accommodate the small syringe that they can fix. So you can fix the syringe here if needed. So this is regarding the injector needle. So please.
Okay. So the second accessory we're going to use, this is the Boston Scientific Captivator, and it is the large one with the medium stiffness wire. So you can see here the specs. Here you can see 30 millimeters, which means this space you can focus here. So it's 3 centimeters, okay? And it's called the large oval because it's oval in shape, and it's the largest. And it's medium stiffness wire.
So I think another important, very important message, that you should not do polypectomy if not you have different size of the snare. So this is a very big one. But we have here, we are prepared for we have a lot of them. So you should, in the clinical setting, you should have different sizes of the snare. So this is, yes, I will focus. So you can see now, yes, Adi is opening the snare and closing the snare. So I know, for example, I have seen Professor Ibrahim years and years that when he was doing this, he always after catching the polyp, he always take the snare in your hand. What you do always, Adi?
Well, I want to mention something first. Knowing the measures of the tool that you use helps you to choose the right tool for polypectomy, and also helps you to measure before doing. So if I'm opening it, now I know it's 30 millimeters. So I can measure the polyp. And even the sheath itself is 2.4 millimeters. So even the sheath itself, I can measure it. I can use it to know the elevation of the polyp. So this is 2.4 millimeters. So if it's double, this means we have 5 millimeter elevation polyp, something like that. So every measure and every length we know about the tool, when it's closed or when it is open, it helps us in doing the right technique.
Okay.
And also
Adi,
we have
Dr. Adi. Dr. Adi.
Yes.
You put a mark on the handle.
On the snare itself, you put a
But you put a mark or not?
Some people put mark here.
No.
When do you know this?
No,
because this is very important. Because this is very important, because when you open it and close it, sometimes you can, by this closing that you are closing the polyp. But if your nurse continue to close, it can catch the polyp without any polypectomy. So normally we put a line when you open the snare, and you close it. When it reaches the end, you make a mark on the handle.
Yes, it's according to the experience of the helping nurse. I think it differs a lot. If she is an expert nurse like we have, and even I can use my hand to know how much length that I'm going in comparing to when it was closed without a polyp. So this will help me to know if I'm closing partially or I'm closing totally. There was a question here I didn't see. And also here we are having the rescue net or retrieval net. The retrieval net is used to remove the resected polyp.
This is the new tool, the new baby from Boston Scientific. So this is the net. Yeah, you can open this, please. So yes, this is the net to capture the resected part. And I think this is in Egypt is not very popular, but I encourage really everyone to have it, because sometimes, especially in the colon, when you resect the polyp, and then you take a lot of time to retrieve the polyp itself. And I think this is one of the very easy tools to retrieve big polyps. So I think it's now available in Egypt from Boston.
Yes, and it's also important for some foreign bodies that cannot be removed easily with foreign body forceps or by snare or by basket.
Adi, there is a question coming from the audience to you. Do you use APC for marking in polypectomy?
Well, actually, in some cases, if the polyp margins are very clear and the polyp size is around less than 20 millimeters, and you are doing polypectomy, not actually EMR, I do not use APC. If it's flat lesion and it's larger than 20 millimeters, I can use APC for marking.
Okay,
yes.
Thank you. So yes. Okay, so I think we are ready to start.
Or only the endoclips,
Yes, yeah, we have the clip.
Yes.
So I think this is another important thing, Adi, that you need to be prepared. So it's sometimes when you are removing a polyp, you said, okay, I need only a snare, but you can see here, this is the things that you should have when you are ready for polypectomy.
Yes, and this is the resolution 360 rotatable clip from Boston Scientific. And as you can see, it needs just working channel of 2.8 millimeter, and it's 203 centimeter in length, so it can work for colonoscope and for upper endoscopy. And we will open it now.
So this is the one of the rotatable clips. So this is, I'm opening the clip now. If you can focus on this hand, yes. And now I will just go beside him like this, and now I can rotate the clip from here. You can see I can rotate the clip very one-to-one movement by this. This is the new version of the resolution clip. So you can really adjust, and it's both direction. You can adjust the direction before, and then when I will fire, I just grab it, and then I will pull more than to fire the clip.
Yes. So I think we are ready now to start our procedure. And
yes,
lamp.
So we have you will see the simulator now. We have inside a lot of polyps. So yeah, please, if you can see the endoscopic view.
I hope you can see the endoscopic image now.
Please, for the control room, could you shift for the endoscopic view? Yes. So make it bigger, please, so you can put the. Okay, so you can see now the polyps. So this is this is really the beauty, the art of our training manager Nuran. She had a lot of polyps for us. She already created a lot of polyps for us. So you are free to choose, Adia.
So it's okay. First of all, these are artificial polyps that Dr. Nuran has made for us. And of course, because they are artificial polyps, if we want to classify them according to Paris classification, they will all mostly have the same classification, which is 1PS, which are subpedunculated polyps. I think most of them are like this. So I have some foreign body in front of the. Yeah. So now we will try to do different scenarios for polypectomy. We will do simple polypectomy. We will try to talk about cold snare and hot snare polypectomy. And we will do something like EMR after elevation of the lesion. And also we can talk about small polyps. If we have smaller polyps less than 4 millimeters, we can do which is called forceps polypectomy. It's without snare. It's just with the forceps. The second thing I want to say that the most important issues in polypectomy are 3 issues. Number 1 is try to avoid or try to manage bleeding if it happens, try to avoid and manage perforation if it happens, and try to be complete resection. Because with increasing the size of the polyp, there is always high risk of complications and high risk of residual lesion. So lesions above 20 millimeters have a carry risk of 30% of incomplete resection. So we will now just say that.
So which technique you will start? So the one you will inject now, the first one, or you will do?
I think.
So we have a question coming for you. Which solution you use for injection now?
Well, I use two scenarios. The first scenario is just to inject saline, but this is in case of just I want to do good elevation, but I can see the margins. The margins are very clear for me. If the margins needs to be more clarified or to be sure that I can see them, I put diluted methylene blue with the saline. So I think we can inject first.
Okay, so we will start injecting. So I think one of the scenarios that already Salma is prepared for us here, this is important. So you have multiple syringes, so you should, because sometimes when you inject, you have only, so this is also for your nurse should be ready with a lot of injection. So you don't put, don't put adrenaline.
No, of course, many people use it, but I think it's just mechanical compression. It's better than the vasoconstriction.
One of the tips also, you need, before you go to inside the scope, to fill the dead space. So I will ask Salma to open the needle. So needle out, inject. I will inject before I go inside.
Yes.
This is very important that we already make sure that the needle is working. Second thing, that we have filled the dead space with the injecting solution, with the needle back. So please. So now it's ready for injection.
So I can go through the cap.
Yeah. So could you have also the endoscopic view, a bigger one, please?
What you inject?
Okay.
Dr. Adi. What you inject, Dr.
We will
Adi?
inject now. We will inject now diluted methylene blue with saline.
Yes, this is very important.
Okay.
What the dilutions?
So
what dilutions?
The dilution, it's different. Actually, I think there is no
guidelines. I think
guidelines for
this.
fixed concentration. Yes. So it's just for visibility for the doctor. But for me, I want 1 to 10. But it's not a fixed figure that I think it's written in any literature.
Okay, so you have the polyps now, Adi, you can see the polyp in the middle of your vision. So where you are going to inject first?
Well, first, the most important thing that always try to know the scope you are using, which direction the tools will come. So the tools here are coming from 6 o'clock, 6 p.m. o'clock, and this is very good position for us. So if I am using, if it's just a small polyp, which means, or medium-sized even polyp, less than 1 centimeter, I can inject just proximal, just here, just proximal, just I'm here. But if it's large polyp, I will start with the distal, the scope with the distal parts, because it will be hidden if I inject here first. So if it's large polyp, more than 1 centimeter, I will inject here first to do the elevation, then come and inject here.
Okay.
So I think for this one, it's if I'm going to measure it, it's less than 1 centimeter, I think. So or around 1 centimeter. So it's not a large one. So I will inject just here. So I will tell Salma just to give me the needle now.
Okay. Put in mind that also this is that tissue. So so it's sometimes in the patients, in the patient we don't have to really pierce a lot. So we just pierce the pierce. Yes, please.
So Dr. Mustafa is saying very important issue. This is a dead tissue. This is not human. So elevation is not like the human. So
just inject.
Inject.
Yes, very good. You can see the elevation.
More. Yes.
So stop 1 second.
So
this is very important. Salma did because she don't have the mic, but she did. She need to tell Adi how much is injecting centimeter by centimeter.
Hold the needle.
Yes.
So
yes,
this is for a dead tissue. This is a very accepted elevation because the module actually is working very good. So now we have done the elevation. And
do you think, Adi, you should have a second injection on at 3 o'clock here? Just a smaller injection here?
Well, I think yes. I need injection here at 3 o'clock. Yes. And also, I want to remind you that though she is injecting methylene blue, it's not very clear here the color of the methylene blue, but in live tissue, we can see it very clear. And regarding the question that I'm seeing now on the screen, how much I should inject? No, I inject till I am having good elevation from all sides.
This is very important. So, and especially in bigger polyps, when you have really a big lateral spreading tumor which are going to resect, I always inject piece by piece. You don't need to really elevate. Smaller polyp like this, it's okay. 1 injection is enough. But sometimes, if it's a bigger polyp, I will inject, resect, inject, resect, part by part.
So give me the needle now, please, Salma. Inject, please. Inject.
Yeah, perfect. Okay.
Enough. So pull the needle.
So you see also this is important in real life that Adi, what did he always tells Salma needle out, needle in. She will never take the needle unless he will say, because sometimes when you just push the needle or pull it, you have bleeding, and we don't need to have any minute bleeding now, because this is when we need to have a very clear vision.
Which snare?
So this is the big one.
The big one.
The small one.
Maybe the smaller.
Yes, because I think we can have the smaller one. We are using also for resection today RB machine. So we are using normally, yeah, again, this is this simulator. So we are going to use a pure cut. However, in patients, we always use either EndoCut Q or I. It depends on the session. It depends on the hospital. But we use always blended carrot. So we are using today the RB generator. Yes.
So now, as I told you first, the diameter of this closed sheath is 2.4 millimeter. So it's almost quarter or less than, or around third to quarter the polyp. So this polyp is 1, 2, 3. So this polyp is around 8 millimeter, as we can measure it here by using the diameter of the sheath. So I will tell Salma to open, please, gradually. And this is enough opening, and I can tell her now to close. But before telling her to close, while she is closing, I will just push the sheath forward in order to keep the ratio fixed. So Salma, please close gradually. No, open please, gradually. Yes, yes, yes.
Very good.
Close, close.
So
yes.
you have seen what Adi did. He was pushing the sheath the same speed like Salma was closing the polyp to have to catch the base of the polyp.
Yes, and now in some polyps, but not in this polyp. In some polyps, I used cold snare cutting, but in this polyp, it does not have a pedicle that allow me to do this cold snare. So I will do hot snaring. The hot snaring is good for hemostasis, but it can do some tissue injury. So just we will do some elevation here, very, very light elevation to avoid more tissue injury, and then I will start doing it. So it's now we have done the resection. The first of all,
what is the first thing you do after resection?
I inspect the site.
The base, yeah, the base. Yes. So this is very important. So the first thing you do is always, because we have a little bit of excited because we have resected something, but leave the resected part and go for the base.
Yes, I go for the base first, and this is not human. This is not the classic. So I will consider now that we are having perforation. Do you like this idea?
Yes, yes. Okay, this is good.
So I will consider that this is a perforation and we want to close it. And after this, we will do retrieval for the polyp. So I'm going to use now the resolution clip.
Okay, so we have a question coming from the audience. Adi, do you recommend a distal cap while performing polypectomy?
In fact, yes, I prefer using the distal cap.
I think the cap, especially in human settings, a lot of good things. One of them is that you not only to position your scope well for the resection, but also it's very important for controlling the bleeding before even the very minute bleeding at the base of the polyp. Because with the cap, so I will never do polypectomy nowadays without a CO2 pump, without an automatic irrigation and the cap. So I think the cap with the automatic irrigator, you have to clean the base and wash the base, and you can identify very small vessels to be coagulated. Adi is stimulating that he has
there is still a small part.
It's
maybe.
This is the secret. This is our secrets where we
fix. Yes.
So this is artificial fixation. This is artificial fixation of the polyp.
Yes. This is not incomplete resection. It's completed resection, but this is artificial fixation. So now I am going to tell Salma, please open
So Adi is simulating a perforation, a minute perforation, and he will close the perforation now.
Yes, and I need some rotation from Salma, please. Yes, rotate the clip, rotate.
So
rotate
you see, Salma did very important thing. She straightened herself. She pulled she straightened herself, being far from Adi while she was rotating, and now she's rotating. A very good position, I think.
Yes,
like this.
I think this is a very good position. So.
And you can see by one clip, you are enough to have, if there is a perforation, a minute perforation, we should not have perforation in a human patient. But again, Adi is simulating the very extreme condition. Very good.
Yes.
So you can see Adi, what he did, he grasped the two edges of the perforation.
You can fire now.
And he fired the clip. Okay.
And this is closure.
Very good.
Actually, I will not retrieve the polyp because it is attached, right?
No, it's not. You can remove it.
Now I can do it.
You can remove it. No problem. Don't worry. Nural is testing our techniques, our technical power. So we will use now the rescue net to retrieve this resected segment. So the tips of the rescue net, okay, what setting of the diet? Okay, so no, here we are not using the true settings because we are using a dead tissue. So in this part, here, we are using a very high auto cut mode. But in human being, normally I will use EndoCut Q with effect 2. But again, it depends on many things. So I think a lot of in the literature, a lot of settings for different polypectomy, but this is what we use for humans.
Yes, please, Salma, open gradually. More. Yes, enough. More, maybe more, a little bit more.
Yes.
Yes. So start closing, please.
So you see what he did? He did the same like he started distal to the polyp.
Close.
Catching the polyp very, very close. Okay, very good.
So now I catch it in the.
So you will take the scope out, huh?
Yes,
you will take everything out.
Sure, I will take the scope out.
So yes. Okay, so now he is taking the scope out. You can show if you can change to the camera. Yes.
And so this is, as we said, it's less than 1 centimeter polyp. And when we want to take it out, I will tell my assistant Salma to open, and I will take it in the tube for histopathology. So, remove it first.
Normally, what I do also, especially in bigger polyps, I will show you something here. When I have the section, I always check like this. I don't know this will be possible on the camera or not. Could you zoom on this? Like this. Yes, you can focus. Okay. Yeah. So this is very important that when you resect something, you put it on just a piece of paper and make sure that you have a continuous resected area. So this means you don't have a perforation. So here I have a very continuous submucosa, which means that I have a complete resection without any residual. So this should go to the pathology. Okay.
I don't know if we have the ability to do bleeding here or not.
No,
I'm not sure.
In this. No. Okay. Yes. Okay.
Lamp,
we have a very tricky question. Do you inject sometimes inside the polyp itself to elevate it, not around the polyp, inside? So you inject inside the polyp. And if you do this, when you do this?
Yes, I can do this if I need more elevation with wider polyps, and especially polyps with central depression.
Okay. So I think if you can show one other techniques of the polypectomy.
So we can choose anyone here and try to do just a polypectomy even without. First, we are checking this is the perforation that we have closed.
I think, Adi, if you can show us also, because for the time frame, if you can resect another one and show us if you have a minute bleeder on the base of the polyp, how you coagulate this.
Okay.
Okay. So you will resect another polyp.
So I will resect another polyp without submucosal injection now. So I need a snare.
Okay, we have another question, Audi, for you. Can you advocate maintaining 2-3 millimeter margin around the polyp during the resection? So yes, this is the typical. So this is why I didn't show this one, because this is simulated. This is very important. We need to resect with the safety margin around the polyp. This is the 2 millimeter around the polyp all through, that you are sure you don't have any residuals. But again, this is what we say, this is the en bloc resection for a smaller lesion. But if it's a bigger lesion, always what I do in bigger lesion, I will start resecting piecemeal resection, piece by piece, starting normally from the distal part to the proximal part without bridges. So the secret word is without bridges. You need to have the complete resection. But again, to answer this question, if it's a smaller lesion, I would love to have always a 2 millimeter rescue zone around the polyp.
Yes, and regarding the 2 millimeter that the question has said, this is by keeping always the closure of the snare not at the neck of the polyp, but just proximal 2 millimeter. So now we will do polypectomy, simple polypectomy for this polyp with a hot snare. So I will tell Salma, please open the polyp now. Open the snare. I'm sorry. So she's opening now. And now I'm going to tell Salma to close gradually. Close, 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 close. Okay. Now Salma is closing, so I will. So you are closing to the max. So now she's connecting.
You see, this is also important. Salma will never connect the electrosurgical unit to the snare before RD tell her, okay, now to connect.
So she's connected now.
And you can start the resection. I think it's resected.
Yes, it's
okay.
resected. So
now we will see. Okay, we will simulate as if already there is a minute bleeding.
Yes.
Only a minute bleeding at the base of the polyp. So what you're going to do with a very rapid one?
Yes. If it's a minute bleeding, so I will do hot coagulation for the bleeding with the tip of the snare. So I'll just tell.
So you will push
Salma,
first this resected segment.
No. Don't tell me to push it because it may not be pushed.
No, you can push it. Okay, don't worry. So
okay, open the snare, please. I'll just pull it. Open more. Okay. So close gradually. Close.
Okay, this is very good. This is another technique without a rescue net that you can capture the resected segment, the resected polyp, where you can just open the snare and catch it from the middle.
So leave it here. We do not want to retrieve it. Open the snare. Yes, close, please. So we will assume that we are having here a minute bleeding in this part. Actually, it's like real. So I'll just use the tip of the snare. Please open a very little bit. Yes, more. This is enough. So I will assume that this is a bleeding, and I will just use the
soft coag, yes. Yes. Okay, so
it's
now
not real bleeding. I'm just telling you that what we are doing.
Okay, Adi, a difficult question and very important question. When you refer your patient with a polyp to your surgeon, to your friend, the surgical department?
Well, there are two types of referral. The first one, if I have complication during polypectomy, this will be an obligatory referral. If there is something like perforation that's cannot be closed by endoscopic measures. And I know that your question is asking about when I'm doing colonoscopy and I see a polyp and just will decide not to do endoscopic intervention for it. Well, if we are having a flat lesion or a very large polyp, and the histopathology here is very, very, very important. If I am having on-site histopathology, and we see that we are even intraepithelial or adenocarcinoma, this is for surgical. But actually, in our practice, not only the size of the polyp, the histopathology and number of polyps. So even if we have seen 100 polyps, like familial adenomatous polyposis and something like that, we will refer to surgery. But even if it is a large polyp and it's by pit pattern and by size, it's resectable even by EMR or even by ESD, it's very rare now to refer for surgery.
Okay. I think, Adi, this
Yes.
is, thank you very much. Really, it was, I cannot tell you how much I'm excited for
Dr. Adi, if the polyp is not elevated by injections.
Well, if the polyp not elevated by injection, I will do further imaging and do biopsy. Further imaging either by EUS to know how much we are going far into the walls of the GIT, either upper or in the colon, and we will do further imaging. So if it's not elevated, but it's not reaching the muscle layer, still ESD is possible.
And even more nowadays with the full sequence
but
resection, especially in the colon,
yes,
possible, yes.
And in the colon, even if it's lesion less than 2.5 centimeter,
we can do the FTRD.
Yes.
But if you have a large polyp, in the transverse colon, and this large polyp you inject and not elevated in the transverse colon or the ascending colon, not elevated.
Yes. Yeah, this is for surgery. Yes.
So I like to say that limitations of polypectomy is very important. Yani, I know that most of you are very expert, but don't make everything easy. Please, if you have a polyps, if you have a polyps which you injected and they cannot be elevated, go to surgery. But to speak about submucosal dissections or something like that, we are not in a position to do submucosal dissections now for a polyp in sigmoid or ascending colon. So you can refer to the surgery. So you should everyone do his limitations, and by his limitations, he can stop. Either to refer to a center which is working on that, or to go to surgery, because at the end, safety of the patient is very important.
Yes.
Okay?
Perfect.
Okay, perfect. Thank you.
Thank you. Thank you. تسلم يا غالية. تسلم يا غالية.
انت على الهوا لسه يا حبيبي. You are in area غالية.
We are not the expert anymore. I think that this and for our friend Abdul from India, there's a small high from Egypt, and if there's any questions, we are here.
So now, now we are. Since all of us are here, I think we'll start by. I think Dr. Start some questions, but I think we'll start by the first lectures, and then we go by first and Azad, and you can stay until you have any questions. So starting from the beginning until the end, because they are waiting you from the beginning. You are waiting for them until they finish. Okay. So now we have a question for the first lectures. You answer some questions. Amul? Amul,
Yeah,
you are here?
fine. Yes.
Yes, yes. Yes,
Yeah,
please answer your questions by voice, because I see that you answer some of them. So answer them by speaking very quickly. Okay.
Okay. So the question was, is hiatal hernia a contraindication for Verdex? So yes, presence of a hiatal hernia more than 2 centimeters is a contraindication.
Yes.
Up to 2 centimeters, we can perform Verdex or many of the endoscopic anti-reflux modalities. But larger hernias require surgery. The next question was, we need APC marking before arms, and is hiatal hernia and contraindication for arms? So yes, we do require marking. We can perform the marking either using APC or a dual knife. It is important to mark so that we can ascertain how much the limits of the resection of the mucosa before injecting in the submucosa, because once we inject, the mucosal appearance becomes very distorted, and it is difficult to ascertain the limits of the resection. Presence of a hiatal hernia again is a contraindication for performing arms.
Okay.
Then There's one question about PS studies, whether they should be performed on PPI or off PPI. So traditional PS study should always be performed off PPI. However, impedance PS can be performed when patients are on PPI as well. And the other part of the question was patients who are non-responsive to PPI, should they be offered surgery? Well, the simple answer to this is probably yes, either surgery or endoscopic anti-reflux modalities. But a more difficult answer is make sure that the patient has only GERD and not just dyspepsia or hypersensitive LES and all other aspects of the GERD paradigm before condemning this patient for any interventional procedure, may it be endoscopic or surgical. The next question is arms or GERDX an option after POEM for symptomatic GERD? So yes, of course, we can perform arms or GERDX after POEM. However, two issues are there in this. One is that this procedure will have to be as a second session procedure after 4 to 6 weeks after all healing has taken place. So it will amount to another anesthesia and one more procedure in the patient. The second thing is probably performing arms is going to be difficult unless you choose the opposite side, because there will be submucosal fibrosis because of the tunnel, and so one cannot elevate the mucosa very easily over there. The next question is, what are the serious complications of GERDX in arms? So complication of GERDX is most common is perforation, because the device is quite rigid, and even when we introduce it over the guide wire, there is a risk of perforation if it is not done carefully. And the complication for arms is perforation again or muscle injury, and second is bleeding, which has to be very meticulously controlled. So these were the questions to me, and of course, Professor Ibrahim have some more questions to me.
Dr. Izzat, Dr. Izzat, Dr. Izzat, Dr. Izzat is here with us. Yes, yes, Dr. Izzat, there is one question about what about dexamethasone as regard to efficacy in comparison to other PPI?
I hear another, we have two questions. One about the presence of H. pylori with GERD. I think it's now ended that you can treat H. pylori with using PPI from the start, then continue after treatment of H. pylori using the same dose or double dose of PPI. Never forget that a rebound hyperacidity which may occur after treatment of H. pylori will not so bad effect with potent and good type and potent type of PPI like esomeprazole. And no contradictory regarding this questionnaire, provided that the patient suffering from some troubles due to H. pylori. As regarding question about dexlansoprazole or double delivery system of PPI, that is dexlansoprazole, it's very good in some cases when, especially in patient with nocturnal GERD, regarding the second curve, which may be a delayed release PPI, help you to avoid a patient with nocturnal symptoms. As regarding efficacy, all of the PPI showing the same potency, especially the new brands type esomeprazole, pantoprazole, and dexlansoprazole, playing a very potent efficacy with a good comparability. But only little help us about regarding the main indication for dexlansoprazole is a dual release to avoid nocturnal GERD.
There is any another questions for you?
Up to now, no.
Up to now,
no.
No. Okay. There is come to the team of the hand-on. Team of the hand-on. Dr. Adi and Dr. Mustafa.
Here.
Yes. Okay.
Yes.
Yes. The first one, it is use adrenaline for injections.
Yes, I think we answered it while we were talking, but Now we depend on elevation and mechanical compression more than vasoconstriction.
Yes.
So actually we use either saline or saline with methylene blue. This is very sufficient.
Okay, setting of diathermy.
Yes, I think I answered this also. So in real patient, with endocut, it depends on between the effect. But in my daily practice, I use endocut with effect too.
To any polyps?
To the EMR1, to the one with the which without any, to the small cystile polyps or even the piecemeal resection, not to the bigger polyps with the big stump. Because in the other, I use another thing. Normally, I put either an endo loop on the base or the new technique of Yamamoto, which show interacting clips, and then I put a higher effect 3, because normally you have a bigger vessel inside which you need to resect. This is in the pedunculated polyps.
So, for me, from view, if you have a pedunculated polyp and you make either, I use coagulations in the coagulations polyps, coagulation current in the pedunculated polyp. You look for the pedicles during cutting. What is the change of colors in the pedicle or not?
Yes.
Yes, of course.
Yes, of course.
What is this? What you use? What you look?
Because of the sometimes of the not availability of the less availability of the endo loop, I nowadays I do more and more this clipping technique. I put 2 clips at the base of the polyps with a 90-degree between them. I wait for a couple of minutes till I see the discoloration, the bluish discoloration of the polyp, and then I will start the resection.
And you start the resections far away from the endo loop or the.
Yes. The clips are better because the clips will stay in position, but I always give a safety of few millimeter above this polyp. I put the clips on the base of the stump, and I cut a few millimeter over the clips.
This is very important because sometimes when you put very near, it slip. Very good. And during using coagulation of the current, you look for, and use without any endo loop or any snare, you look for the current, for the change of current of pedicles during coagulation or during cutting.
I didn't get it.
So yes, if you are not putting an endo loop or you're putting a clip and you are just cutting the clip with the coagulation current, not with the cutting current, so you look to the bluish discoloration within the process that you are coagulating the base. So it will start having the blues. This means that you're decreasing the blood supply.
Yes. We notice it because coagulation is closing the blood supply, so we are getting the ischemia and bluish coloration. So yes, we notice it very easily. Yes.
This is I think very important. So cut the polyp with the long pedicles. When you cut it, if you see that during coagulations or during cutting, that there is spread of coagulation coming down, that you know that if you cut now at that time, you can use. Normally, you use the snares, use the nurse to hand the handle. So all of you using that?
Yes, but again, as Adi said, it depends of the nurses. So because we personally, we don't work with, let's say, very non-experienced nurses. I work only with experienced nurses. So it depends. If you are working with a non-experienced one, we should handle it ourselves. Yes. But in our setting here, we are really having the best nurses. So I will let them handle everything.
But I still, until now, I use the handle on my hand because I get the feeling of that, and I use also the mark. I think the mark, if you can possible to show them the mark, because this is very efficient for the beginners for polypectomy. Can you show them how to make the mark?
Yes. Sure. Yes. There's a snare.
You have a mark?
Yes, I can get you a mark.
Because this is very important, Adi, for anyone who's starting to understand what's mean by that. This is written very, very early, but I use it until now. Myself, I use it until now because
yes. You can do it. Yes. Okay. So.
Okay, you can.
Okay, so yes, what Professor Ibrahim is just telling us that. On the handle here, we can mark. So I will open a little bit. if you can see, yes, I can open the snare, and then when we start closing, let's say this is we know okay, this is the size, we don't want to close more than that. We can always mark it here like this.
Yes.
So we can mark it here, so we know that when we are closing, we should not cross this.
Yes. To know
So
the
this
stop
is
point.
to know when
now,
to stop.
very good. Very good. You can tell Adi, no, Adi, continue by that, by both hand of the mark, and your hand, Madi, focus more. Yes, very good. Make the mark, put at the mark. Yes. Now,
Yes.
still like that. Close now, close totally.
If I close totally.
Totally. Show me where is the snare now, when you close totally.
No, it's all inside.
And how many outside?
It's nothing outside now because I crossed the mark.
So now it's a big part from here up to the end. So if you close it like that, by your nurse, you will crush the polyp. And this is
Yes,
for
crushing the polyp. Yes.
Okay.
So if I stop
Okay.
at the mark, it will be like this.
So you understand that the mark that you are catching, or more than that, you are catching the polyp, so you can use it.
Yes.
Okay. Detailed examination of using enhanced endoscopy play a role before planning.
Sure. Yes, I think yes. Sure. This is a question that nowadays it's, I think, part of the it's a mandatory thing. We will not resect polyp without doing a full examination for the polyp, as like Adi was explaining, assessing the pit pattern, assessing the mucosa of the polyp itself, of the surrounding mucosa, and classifying the polyp without resection. So I think we should all do this. This is part of our routine now. By the new scopes and the new imaging enhancement techniques, polyp classification is mandatory. I know that in Egypt, this is not an everyday procedure, but we should all start doing this, especially in our reports. We should report really the classification of the polyp before doing anything.
So I think this is all the questions coming to all of you. And it's very nice demonstrations of polypectomy, also of different technique, very nice closure of perforations, and also how to inject, what is the type of injections. And this is a very nice demonstrations like live. I think it will be very beneficial to anyone who like to start polypectomy, to get some lesson about that. It may be more effective than live, because all of them are very calm, and you make perforation, you don't afraid, and you make bleeding, you don't afraid, because so this is, we can get, I think, more learning by hand-on, and this is around more than 200 people now looking for you and learning how to make polypectomy. This is maybe very difficult during live or during hand-on stations because the little number. So I think this will be very efficient for training, and I think when it's increasing, we'll have many questions if you go more deep, like hemodynamics and US and something like that. There is one question now, I think for both of you, I thank you very much for these highly demonstrations. And there is one question coming, I think it's the end. It's for Dr. Izzat. Yes. Dr. Izzat, for refractory gel, use Vidiclofan?
Baclofen.
Yes.
Yes, we have to know that the baclofen is GABA beta agonist. It decreases the lower esophageal sphincter relaxation. It play some in the study some good benefit in decrease the symptom of GERD. However, it's not established inside the guidelines as a drug of treatment for long term in cases of GERD, and they recommend more and more detailed randomized study to get it inside the guidelines. Using tricyclic antidepressant, SSRI, in refractory GERD, we go back to the causes of refractory GERD. We use it in non-GERD related, that is the esophageal hypersensitivity maybe play a role using tricyclic antidepressant and SSRI I will consider them as not a refractory GERD, we consider them as esophageal hypersensitivity. Thank you.
Thank you, Professor. I'd like to thank Professor Amwal from India for his nice lectures and the techniques of endoscopic management of GERD, which is, then we go to Egypt and not to Cairo but to Alexandria, a nice places. I enjoy very much to visit it. Professor Izzat to demonstrate the use of BBI. I'd like to thank the team of Hand-On, Dr. Mustafa and Dr. Adi, for very nice demonstrations. We give him a very difficult questions, and also this is very important, and we hope that by next time the questions of Hand-On increasing, because this is, I think, one of very nice mode of education. I'd like to thank all the team working outside the camera, like Nuran and like Marwan, and like all other nurses. I like the nurses. I like the company which organize the funding. So everything running very good. At the end, we like to speak about the company which is behind that, which is AstraZeneca, which is a very high level of encouraged education since many years, and she is working for that. And as you see, they have nothing with polyvectomy. They have the endoscopic management of GERD is against them, but we try to present all the view not to sell drugs, but to give science. And this is what we need, to give science to people education and what's true and what's not true. So I thank you, I thank Roya for that, and I hope to see you very soon in another very nice webinar like that. And thank you. Thank you. See you very soon.
Okay, bye-bye. Thank you.
Bye-bye. Bye-bye.
Thank you very much, Professor Ibrahim.
Thank you. Thank you very much. Thank you.